Good morning all. Thank you for the kind introduction, and I thank you Endocrine Society of Rajkot to invite me for this particular talk. So diabetes management is quite huge and vast, and this topic is also quite vast. I'll share you few cases which I have come across in last few years. To start with, this 70-year-old man, he is a known case of diabetes since 12 years, and this patient is recently diagnosed to have metastatic prostate adenocarcinoma. And you might have heard about this drug, abiraterone. It is one of the drugs which is used in prostatic cancer. So this patient is started on abiraterone and prednisolone, and he is on OHs, glimepiride metformin twice a day and sitagliptin metformin once a day. And this patient came to me with history of hypoglycemias, early morning hypoglycemias. So in such patients, whenever you come across hypoglycemia in clinical practice, your first doubt should be you should look at creatinine. In this patient's creatinine was normal. So what next? Then I stopped at the night dose of OHO. Still the hypoglycemia persisted. So you need to think beyond just OHs and insulin. Why? Because abiraterone blocks adrenal steroidogenesis. The primary intention to give abiraterone in such patients is that you want to block the testosterone synthesis from the testes. But at the same time, abiraterone also acts at the adrenal cortex. So it blocks 17-alpha hydroxylase enzymes. So once this enzyme is blocked, even the cortisol levels go down. So the cortisol and testosterone is going down, and you're blocking the primary step. Aldosterone and corticosterone synthesis goes up. So at times these patients can present with hypokalemic paralysis as well. So there was a case recently in another hospital. One of the clinician was discussing with me. The patient had hypokalemia, and every single investigation was done. At the end, it was found out that abiraterone is causing increased mineralocorticoid and hypokalemia. So why this early morning cortisol is required? So in a normal person, ACTH starts rising early in the morning, 4 a.m., 5 a.m. And by the time you get up at 7, 8, your cortisol is also at peak. So that is the reason we check early morning cortisol to know the cortisol reserve in the body. So this cortisol is also useful in, it is a counter-regulatory hormone, it is a stress hormone. So whenever your body's glucose level is going down, it is body's response to increase cortisol and epinephrine. But if the cortisol synthesis is blocked by abiraterone, this won't happen. So in such patients, you need to have frequent monitoring of blood glucose levels and then decide. And in such cases, you should not often use long-acting sulfonylureas. You can use short-acting analogs like repaglinide, vagara. And at times, because you're giving abiraterone, which is known to block cortisol synthesis, all the patients are on steroid at 0 hours only. But sometimes you might need to give steroid twice a day. So in such patients who are having frequent hypoglycemias, you might consider giving prednisolone twice a day as well to counter the hypoglycemias early in the morning. So this was one case, and as the cancer prevalence is going up, you might encounter such case in your clinical practice. This is another case which we saw in KM. She is a young female with diabetes. She was diagnosed to have diabetes because of infection, carbuncle, and despite on 3 oral anti-diabetic drugs and insulin, she was uncontrolled. And if you look at her, though she doesn't look classical Cushing syndrome, which you see in books, she does have mooning of faces, despite being lean. So this part of the face should be little deeper compared to the maxillary prominence. If you look at her face, she is having rounding of face. So that is the reason she was suspected to have Cushing's, and her basal cortisol was 20, and overnight dexamethasone suppressed cortisol was 15. So she was diagnosed to have Cushing's disease because her ACTH was elevated, and the MRI was showing pituitary adenoma. So whenever you suspect Cushing's, a simple test you can get in your clinical practice. So if you look at the literature as well as in clinical practice, the most common cause of Cushing syndrome is exogenous steroid use. So patients who are having some alternative pathy medications or having topical steroid creams, those are the most common patients who will have Cushing syndrome. But when you get 8 m cortisol in such patients, if the 8 m cortisol is beyond 5, you can proceed with the next step to get overnight dexamethasone suppressed cortisol. You give 1 milligram dexamethasone at 11 p.m. at night. Next morning, you check cortisol level. If the cortisol level is not below 1.8, in a normal person after dexamethasone, cortisol should fall below 1.8 microgram per deciliter. If it is above, you can proceed further with further investigation, and you can take endocrinologist help. And it can, based on the ACTH, it can be ACTH dependent or ACTH independent Cushing's. In ACTH dependent Cushing's, patients can have pituitary adenoma, it might be producing ACTH, or it can be a pulmonary neuroendocrine tumors or pancreatic neuroendocrine tumors, as shown by the last speaker. And sometimes it can be a primary adrenal pathology, adrenal adenomas secreting cortisol, or adrenal carcinoma secreting cortisol, which can also lead to Cushing's. So the management is surgery. In this particular patient who was operated, after 12 months of surgery, you can see that her cortisol, ODS cortisol dropped from 15 to 3. There was improvement in the glycemic parameters. Her OHA requirement came down. But Cushing's disease is a very, very notorious disease. It will keep coming back. So even after the first surgery, even if the patient is labeled to have cure, you need to keep close follow-up because they might have relapse very commonly. And as like in this patient, she was never cured. ODS was still high, above 1.8 even after 12 months. But afterwards, it kept on increasing. So she required radiation therapy. And after the radiation therapy, gradually she improved. So in Cushing syndrome, because of the high cortisol, there are multiple mechanisms which can lead to diabetes. Direct cortisol, it can lead to decreased gene expression of GLUT4 receptor genes, which is required for glucose entry into the cells. Also, because of high cortisol levels, it can lead to hypokalemia, again beta cell dysfunction. So these are the different manifestations of Cushing's. You need to be having very strong suspicion, and please rule out exogenous Cushing, which is very common. Please get 8 m cortisol whenever you are in doubt, and if the 8 m cortisol is less than 5, that is the time you label that patient might be having exogenous steroid related Cushing syndromes. You need to give replacement of dose of steroid. You need to give at least 2.5 milligram prednisolone till the patient's own axis recovers. So they can present with mooning of face and plethora, and after the surgery, the same patient is unrecognizable. They can present with catabolic features. The skin collagen is broken down, so that is the reason skin is so thin, it will start separating from each other, and it will lead to reddish or purplish striae. If you look at in your clinical practice, sometimes obese people come with striae. They are having obesity related striae. Their striae is elevated. These striae are depressed because collagen is broken down. Obesity related striae are whitish and they are little elevated. And after the surgery, you can see that even the color of the striae changes to normal. They can have catabolic manifestations in the form of vertebral fractures as well as severe myopathy. This is one patient which we saw in KM. He had neuroendocrine tumor sitting in the mediastinum, and he was having ectopic ACTH syndrome leading to severe Cushing's with myopathy, pupil edema, and after the surgery, the same guy, the mooning, plethora, everything decreased, edema disappeared. So there can be remarkable benefit if you diagnose these patients well in time. So high index of suspicion is needed, and ODS cortisol, that is overnight dexamethasone suppressed cortisol, is a simple test which you can do in your clinical practice. Another case, this young man I saw just 9 months back. He was 42 years old, and in the routine preventive health checkups, which is offered by a lot of companies now, it came that his fasting sugar was 94 and his HbA1c was 8.9. So initially we thought that his HbA1c might be erroneous. We repeated HbA1c from another lab. Again it came around 8.7, 8.9. So I ordered HB electrophoresis, which came normal. So whenever you encounter such patients, you should go for gold standard test. So what is gold standard test to diagnose diabetes? Oral glucose tolerance test. Take fasting plasma glucose, then give 75 gram glucose in 200-300 ml of water, and then take 1 or 2 hour samples. You can also order another test, that is fructosamine. So HbA1c reflects glycemic control over last 3 months. Fructosamine is another parameter which is glycation of albumin. It is a glycated albumin. It reveals glucose control over last 3 weeks. So in this patient, his OGTT fasting was 86, 1 hour was 154, 2 hour 129. So it was clear that he is not having diabetes based on gold standard test, that is OGTT, and his fructosamine also was normal. So fructosamine last 3 week sugars absolutely normal. The range is up to 300. His value was 197. So the final diagnosis was he was having normal glucose tolerance with positive glycation gap. So glycation gap means whenever there is discrepancy between the sugars and HbA1c, it is called as glycation gap. And there are many factors which can affect this glycation gap. So whenever in doubt, you should go for CGM readings. If CGM is not available, you can ask patients to go for continuous self-monitoring of blood glucose chart. So even in diabetic patients who are having known diabetes, sometimes their blood sugars might be very high and HbA1c comes 6.8 and 7, and he is given false hope, or he is in false sense of happiness that everything is normal. So you should look at the complete picture, not just at HbA1c. And the next speaker is going to talk about this HbA1c in detail, so I'll skip this slide. Another patient, she is 38 years old female, known case of labeled to have type 2 diabetes since last 3 years, and she was on multiple OHs. Look at her dose of OHs. She's on maximum dose of glimepiride, that is almost 8 milligram per day, full dose of metformin, full dose of vildagliptin. Despite multiple OHs, her blood glucose levels were so uncontrolled. Fasting 158, post-meal 290, HbA1c was 10%. So whenever you encounter such patients who are uncontrolled, you should look at simple parameters. Look at their height, weight, calculate their BMI. In this patient, her BMI was 18.1 kilogram per meter square. So this is kind of lean diabetes mellitus. So whenever you encounter lean diabetes mellitus, you should consider either LADA or pancreatic diabetes or some monogenic diabetes. So in this patient, whenever you encounter such patients, please go for C-peptide test. So you can calculate C-peptide either in the fasting state or stimulated C-peptide after mixed meal or glucagon. So in this patient, the fasting plasma glucose was 150, C-peptide was 0.7. So if it is less than 0.6, it is poor reserve, but if it is around 0.7, you can, so it is a continuum. There is no 0.6 or 0.7 is not different for us. And this is on, despite being on OHs, she is already, her beta cells are getting stimulated by 8 milligram of glimepiride every single day. Despite highest dose of sulfonylurea use, her C-peptide was so poor. And GAD antibody was strongly positive. So this patient was diagnosed with type 1 diabetes. So type 1 diabetes diagnosis might get delayed because of this variant, LADA. It is a slowly progressing type 1 diabetes. The beta cells are destroyed by immune system slowly. So that is the reason they don't present with DKA. They present with, their presentation is like type 2 diabetes. Initial response will also be little good because there is initially significant beta cell reserve, and as the cell reserve goes down, the glucose control goes for a toss. So this is, initially they will respond and gradually beta cell failure happens. So you should always get fasting C-peptide or stimulated C-peptide GAD65 antibody, and you can make the diagnosis. And why this diagnosis is important? So once you know that patient is having LADA variant of type 1 diabetes, you can take out the sulfonylureas, and you should just you put the patient on basal bolus insulin regimen, because that is going to preserve the residual beta cells, and patient can do well in the future. And somebody asked, type 1 diabetes, can it come at 40, 50? So type 1 diabetes can come at any point of time in life. Even 70-year-old elderly person can present with type 1 diabetes. It is like autoimmune disease. Like Hashimoto's thyroiditis can come at the age of 2 years also, it can come at 8 years also. Similarly, type 1 diabetes can present at any point of time. So whenever you see the lean patient with poor control with OHS, suspect and diagnose. So how they are different from type 2 diabetes patients? For example, you are encountering a 70 kilo type 2 diabetes person with compared to a 45 kilo type 1 diabetes or LADA patient. How they are different? Because type 2 diabetes patients will have inherent insulin resistance. So their insulin requirement will be higher. Even if they are going for little beta cell failure, they might be having significant insulin resistance in the background. And in type 1 diabetes or LADA, because they are very lean and thin, if you give higher dose, they will go into significant hypoglycemia. So your dose requirement is different, and titration and close monitoring is required. So these are the different factors, suspect, test, and then diagnose. Another case, he is a 48-year-old male. He was just recently admitted 5-6 months back in a small hospital, and the patient was admitted because his HGT was more than 400 milligram per deciliter. And he was already on again full dose of metformin, sitagliptin, pioglitazone. Despite multiple OHs, he presented with HGT of more than 400, and the clinician ordered 400 hai to 12 units actrapid de do. The patient received actrapid 12 units, and after 3-4 hours, patient landed into hypoglycemia. Then that physician called me, there is something which is I am not able to understand, can you have a look? So when I went and saw that patient, again this patient was lean and thin, height 164, weight 49, BMI was 18 only, and on inquiry only, he gave that his maximum weight at one point of time was 75, 78, and now he has become 49 kilos over last 6-7 years. And so whenever you encounter such patients, you should always ask about steatorrhea. Do you get oily stools whenever you're having oily food? And this patient revealed that he was having steatorrhea whenever he was having even little excess oily food. So again, lean patient, go for C-peptide, either fasting or stimulated. His stimulated C-peptide was 0.9. So the simultaneous blood glucose level was 300. So though if you look at C-peptide in isolation, it looks like there is little reserve, but For the blood glucose level of 384, it was fasting was not, it is post-meal C-peptide only. In the background of 384 blood glucose levels, the C-peptide was very poor. So I always give example to my patients. If a car is running at 30 kilometers per hour speed, and if you are looking at the car from the distance, you might say the car is running fine. But if I say the car is in 5th gear, you will say car is defective. For a 5th gear, the speed should have been 80-90 kilometers per hour. Similarly, C-peptide and glucose, they are read in the background of each other. If the blood glucose is 200 and 300, in a normal person, C-peptide should have been 3 or 4. Despite 400, his C-peptide was 0.9, and on CT scan, patient was having pancreatic atrophy with multiple introductory calcifications. So ultimate diagnosis was the patient was having pancreatic diabetes, chronic calcific pancreatitis. Again, there is progressive inflammation, fibrosis, stone formation, and whenever there is stone formation, the pancreatic enzymes cannot enter the intestine, and they will start digesting the pancreas itself, and ultimately it leads to multiple calculi and atrophy. So how it is different from again type 2 diabetes? Because here the patient is losing both endocrine and exocrine aspect of pancreas, and in the endocrine aspect, patient is losing both beta cells which produce insulin as well as alpha cells which protect from hypoglycemia. So in these patients, both insulin and glucagon is not there. So that is the reason. And similarly, because they are lean and thin, they are insulin sensitive, they are not insulin resistant. And that is the reason when the clinician gave 12 units of actrapid at 400, he landed into hypoglycemia because he is not having glucagon reserve to counter the hypoglycemia. And apart from giving insulin, you should also give a pancreatic enzyme replacement therapy in such patients. And another pointer, these patients at a higher risk of getting into pancreatic carcinoma as well. So if you look at the general population risk versus patients with pancreatic diabetes, the risk of getting into pancreatic carcinoma is almost 5 to 10 times. So you should have yearly CA19-9 as well as a part of routine monitoring. So there are different etiologies. Sometimes you might be encountering a patient who is having alcoholic pancreatitis, recurrent pancreatitis, and presenting with pancreatic diabetes. Another common etiology which is missed by clinicians many a times, patient is having obesity with high triglycerides. So any triglyceride which is beyond 600, 700 is a risk factor of getting into pancreatitis. So if you take 10 patients of pancreatitis, 1 out of these 10 patients will have pancreatitis because of high triglycerides. So in clinical practice, if the patient had history of pancreatitis, please look at calcium, please look at triglyceride levels, alcohol definitely, and also look at other factors. Very rarely there can be genetic predisposition to go into pancreatitis because of some genetic polymorphisms. Again, treatment will be basal bolus insulin with exocrine pancreatic enzyme replacement therapy as well. And sometimes for pain or something, you can offer surgeries. To summarize, the first case, abiraterone in prostatic carcinoma, it can lead to hypoglycemia. You need to have optimized the management, the OHA, optimized steroid dosing. Cushing disease, again, the most common cause of Cushing's is external steroid abuse. And then comes endogenous Cushing's disease. You should have high index of suspicion. Overnight dexamethasone cortisol test is easy test. You can rule out whether the patient is having Cushing's or not. Glycation gap, mismatch between blood glucose levels and HbA1cs. LADA, these patients can have diabetes since 3, 4, 5 years. So in clinician's mind, they might think that patient को 5 साल से diabetes है, how can the patient be type 1 diabetes? So patient can have slowly progressive type 1 diabetes, that is LADA. And again, lean patient with steatorrhea, please suspect pancreatic diabetes. Yeah, thank you.